get things started. All right. Oh, sorry. So yeah, feel free to join there, and we'll start off in a sec. Very creative names here.
For those who are just joining us, we're just doing a short little cohort to wake ourselves up. A couple of questions on last year's content. Yeah.
I think we'll just launch into it. We might as well, because we're like 8 minutes in. I don't want to drag it too long. So, okay, going. I won't lock it, so you guys can join at any time. All right. All right, so which nerve is going to be damaged when we fracture the humeral shaft? Very nice. Okay, most of us got the radial nerve. We got a couple answers for axillary or medium. So axillary is basically a bit too high up for us to consider it the main one at risk, and medium basically isn't as closely associated with the humeral shaft. So if you guys remember, we have that sort of radial groove in the humerus, which means that the radial nerve runs really, really close to the shaft, and when that shaft breaks, it can be at a lot of risk. Awesome. To anyone just joining, feel free to hop in on the Kahoot using that link, the code in the bottom right corner. It's still unlocked. Nice. Okay, so this is going back to rotator cuff muscles, if you guys remember that SITS acronym. Okay, interesting. All right, would somebody else from the team like to jump in on this one? That's you guys. Deepak, I saw that. Come on.
Wait, I think it does attach to the greater two hole.
Yeah, I think this might be. I think this question might just be wrong. Yeah, I gotta take whoever wrote this one last year to task. Okay, fair enough. Now you guys were hard done by the quiz. That's our fault.
Yeah, so the subscapularis is the only one that inserts into the lesser two. So guys, great work, keep it up.
Easy. All right. We'll post hoc give you guys 1,000 points each for that one. Okay, nice. So it looks like we're pretty solid on this one. And yeah, it's basically what it says on the tin. So the axilla is right in front of the head of the humerus, basically. And so if we dislocate sort of anteriorly and inferiorly, which is the usual dislocation sort of pathway, we're going to smash right through it. And that's obviously going to be bad for the nerve. Very nice. Right, so this is a partial abduction. It's possible, but full abduction is not possible for some reason. Nice, okay. So we went for the axillary nerve. Would anyone be able to chuck in chat or unmute and say what muscles might be affected here? What we think might be preventing them from getting to a full vertical position? Deltoid, yeah, pretty good. All right. Smiley face with many mouths is doing well. Right, next question. This one's in the image, bit of a long one. Here we go. Okay, right, so a bit of a split there between the deltoid on inversion and the anterior talofibular on eversion. So basically it comes down to, those are the two correct associations. So deltoid is usually injured in a inversion injury, and anterior talofibular is injured in a eversion injury. In general, inversion is a little bit more common when we're talking about ankle sprains. So well done to the guys who got that. Interesting. Okay. So we have a few different answers here. So anterior cruciate ligament and medial meniscus would both have been accepted. I don't know why the green answer is the same as the other one. So I think that's another one that we, another error that we carried over from last year by mistake. So bad there, but well done to you guys for getting ACL and medial meniscus.
Adding on to that, that's if you guys look up the unhappy triad, a lateral blow to the knee will cause those three muscles, or those three things, to be damaged together.
Yeah, sorry, I can't pause this.
That's okay, sorry.
But yeah, good to know that that group of muscles is often going to be injured together. Nice. Okay. So we got two answers here, both pretty confident, and that's really good. So you can sort of remember it as sort of the valgus force, sort of like knock-kneed. So if you imagine like the stereotypical, like if you're really nervous, your knees sort of turn inverse. And every time the leg is bending a certain way, one side, on the side of the interior basically of that curve, is not particularly strained, whereas the side on the exterior of that curve is particularly strained. So when we have a valgus force and they're both going inwards, we're straining the median collateral ligament, whereas when we have a varus force, we're straining the lateral collateral ligament. So well done to you guys. Interesting. Okay. Does anyone else from the team want to hop in on this one?
Yeah, so for the caval hiatus, so remember that would be inferior vena cava. Superior would be superiorly coming into the right atrium. So esophageal, remember that obviously your esophagus, azygos vein, thoracic duct, and your vagus nerve. So it would have been right and left in the thoracic compartment, and then it becomes more anterior posterior. And then, so we've gone through, and then in your caval hiatus, you also have your phrenic. And then finally your aortic hiatus. Sorry, I think azygos vein and thoracic duct, aortic hiatus. Esophageal is esophagus and the vagus nerves. Not bad. Anyway, superior vena cava for caval. Inferior.
Yeah, that one's a little bit tricky because we've played with the words there. But yeah, obviously the superior SVC is not going to be going through the diaphragm.
Yep. Wait. A good way of remembering this is if you look at vena cava, it has 8 letters, so that hiatus would be a T8, and diaphragm has 10 letters, so that hiatus would be, esophagus has 10 letters, so that it's T10, and aortic hiatus, like the phrase aortic hiatus, has 12 letters, and that's T12. So that sort of gives you a good way to remember the basics, and then you fill in the others from there.
Yeah, that's a really good mnemonic for remembering those 3 hiatuses that you want to be on top of. Okay, this one's interesting. So basically, this one is a bit like you can sort of go through each answer and pick off why they're wrong or right. So the first one, I'm glad none of you picked it because the liver is on the right side, and so it it pushes up the right hemidiaphragm. So we'd expect to see the right hemidiaphragm actually be higher. So if the left is higher, something's gone wrong. The damage to the left phrenic nerve does work. So we're assuming in this case that the chest X-ray would be on inspiration, in which the diaphragm is contracting. As we know, the diaphragm is sort of lifted at rest and then it goes down when it contracts, which means that if the left phrenic nerve is damaged, then it doesn't go down enough on the left, and therefore the left ends up being higher than the right. Okay, yeah. The right vagus nerve wouldn't really have much impact because it doesn't innervate the diaphragm, and abnormally enlarged left ventricle, if anything, would push down the left hemidiaphragm. All right, this one's pretty classic and pretty pathognomonic. So see if you can remember what hoarse voices are usually a sign of. Okay, nice. All right. So yeah, the left recurrent laryngeal is really like what we're going for here with the buzzwords. So hoarse voice is very, very sort of pretty much exclusive in terms of when Monash is throwing these questions at you to left recurrent laryngeal nerve palsy. And the reason cardiac surgery is thrown in there is because, as we know, it loops down around the aorta, and so it might be damaged when we're going to have when we're having surgery to it. That's sort of a continual theme, is that if you have surgery in a particular area and there are important neurovascular structures or whatever passing through there, then that can obviously end in damage and complications relating to that. Awesome. Coming back to cardiac in general now, which heart valve has only 2 leaflets. If any of you guys are late arrivals, feel free to join using the pin on the bottom right. Nice. Okay, we're all pretty confident with mitral, which is good because the tricuspid valve, as the name suggests, has 3 cusps. And the aortic and pulmonary valves, also known as the semilunar valves, naturally have 3 cups. You can actually have congenital defects in which your aortic valve, or more rarely your pulmonary valve, has 2 cusps, and that actually puts you at higher risk of aortic stenosis. But that's quite rare, so I definitely wouldn't be expecting that. Nice. Nice, awesome. Would someone from the team like to jump in this one real quick? Why we get filling during diastole, not systole?
Yep, sure. So if we think about where our coronary arteries are, they are just above the aortic valves. So once the blood is pumped out of the aorta through systole or during systole, and it's sort of in the aorta, during diastole, as the heart relaxes, there is filling of the gaps between the heart valve and the wall of the aorta. And as blood pools there, it ends up sort of tunneling and channeling into the coronary arteries, which in turn perfuse the heart.
So, can you see the thing?
Yeah, exactly. Yeah. So those are the heart valves, and it sort of like pulls in those 2 things, like the gaps during diastole, and is carried away through the coronary arteries. During systole, of course, you have a lot of pressure pushing blood through those valves, so you don't have blood pooling there in order for it to enter the coronary arteries.
Perfect. All right, let's keep going. That's a little bit tricky because congenital heart disorders aren't often on your radar, but it is good to know. Okay, so a couple of you guys went for great artery transposition. Now that's going to mean that the pulmonary artery connects to the left ventricle and the aorta connects to the right ventricle. So because the right ventricle takes in deoxygenated blood from the venous circulation, obviously, that means that we're just pumping it straight back out. Like we are bringing in blood to the heart and then we're sending it straight back out without actually oxygenating it. So that's going to make it cyanotic. Another good reason why cyanotic heart diseases can be important is if you remember clubbing. We have a few disorders where it's pretty obvious that where it's more clear how it happens or that it happens in the first place. So several forms of respiratory disorders or metabolic disorders. But in heart diseases, often we get clubbing in cyanotic heart diseases. So good to remember those ones. And basically all cyanotic means is that we are pumping out deoxygenated blood. Well done to the person who got it. Right, a little bit of neuro. Nice, okay. Would someone from the team like to jump in on this one?
Yeah, so at this point, I think you're just meant to know that the SMA and PMA help plan motor function, whereas the primary motor cortex actually, I guess, starts the motor plan or starts the action. But as you do more neuro stuff in year 2, then you'll learn it in a bit more detail.
Awesome. Nice. So it looks like none of you fell for the little, well, sorry, one of you fell for the nociceptive C fibers. But yeah, the first response to pain, the initial one, is going to be it's going to be taken by those type 1 A delta fibers. If you remember, the A delta fibers are going to be more sort of thick and able to conduct that signal better than the C fibers. So that's going to be helpful there.
Yeah, just remember myelin conducts those impulses or the depolarization well. So the more myelinated it is, the faster the conduction. And so if we're just comparing pain fibers, then A delta is going to be better than C fibers because C fibers aren't myelinated.
This one is another question in the image. Talking about metabolic control this time. How we control blood flow through capillaries and the local tissue. Right, I think that one might have been a bit niche. Deepak, did you write this one?
Yeah, I might have done. It's been so long that I don't really remember.
Yeah, fair enough. So yeah, this one is fairly straightforward though. So basically we have metabolic control in all tissues, so we're not going to isolate it to certain types. That green answer is very mean to poor old Deepak. Right, MAP, important thing to know actually, if you want to talk about vitals in a clinical setting. Okay, interesting. So we've got a bit of a split between 100 and 112. So in general, the rule of thumb is you take the systolic pressure and the diastolic pressure, and you divide the difference between them by 3, and then you go 1/3 up from the diastolic pressure, and that gives you your mean arterial pressure. And basically that's just accounting for the fact that your blood pressure spends more time down near the diastolic blood pressure than it does at the systolic pressure. Sort of peaks towards the systolic one. Nice. In neck and neck at the front here. Nice. So yeah, basically the heart sounds are all due to closing of valves, and so the first heart sound happens when the atrioventricular valves close, so the tricuspid and the bicuspid or mitral close, and that's why it's the quieter one. And whereas the louder one, the second heart sound, comes when the aortic and pulmonary valves close. Basically, you can think of it as like when you've got a door open and wind is going through it. It might make sort of a whistling sound, but just make that louder sound. Whereas when you slam the door shut, then it does make a really big sound. And that's what you're hearing when you listen to a stethoscope. Atropine, you guys might remember some of our SLUD and anti-SLUD effects. Okay. Would somebody from the team like to help on this one?
Yeah, I can explain this one. So it's fairly straightforward. So atropine is anticholinergic. Just think like anti-parasympathetic, and therefore it has to be like anything in this list that is a sympathetic response, because it's the opposite of parasympathetic. So remember that when you're doing sympathetic, it's flight or fight. So things that will allow you to be able to survive. So pupillary dilation, to be able to get in more light into your eyes, is definitely one of those responses. You don't want to be salivating. You're not going to be going to the toilet more. You're not going to be crying. So the main things are going to be like your eyes or pupils opening up a bit more. Yeah.
Awesome.
Adding to that, specifically the muscarinic ACH receptors, by the way, just a bit more detail.
Interesting. Okay. So well done to you guys for getting BNP, because even though it's called brain type natriuretic peptide, it's actually has much more to do with the heart. Creatine kinase MB is also specific to the heart, and of course troponin is a classic. Perfect. GTN, if you guys have forgotten, is the nitrate spray. Okay, so Denethil, somebody from the team want to hop in on that one? A little bit of farm knowledge.
Yeah, it's a pretty quick one. Like it's a basic contraindication that you might have seen in your lectures, just like nitrates and like you might know sildenafil is Viagra basically. So nitrates and Viagra you don't put together because they both cause hypotension. So if you combine them, you're going to cause way too much hypotension, and that's not good. At least that's what I'm remembering. If anyone wants to correct me. Awesome.
Yeah, I think just remember that they're both directly venodilators. Whereas say like propranolol is a beta blocker. So it will, to a certain degree, it might cause hypotension, but not same mechanism of action exactly. So that's why those two are specifically contraindicated.
Yeah. So we always want to keep things in a good balance. We don't want to overcorrect in either direction. Awesome. All right, this question is in the image. Interesting. Okay, we got a couple different answers for this one. So let me show them here. Actually, will help a little bit on that one. Actually, did anyone here write this one? Because I remember I didn't write it last year.
It would have been me actually, so I can step in and give an explanation for this one. Yeah, wait, can you guys hear me by the way?
Yeah.
Yeah.
Okay, perfect. So you have learned about these two sort of injuries, Erb's palsy and Klumpke's palsy, which affect the nerve roots, and also the classical ways you can injure them. So over here, what's happening is the mechanism of injury is the person's grabbing onto a branch during their fall and injuring the nerve roots in the lower part, which is C8T1. And that's what's like causing sort of the distal effects of it, which is I think it's called the wader's tip sign, where your hand is flexed and pointing outwards. Oh, I'm thinking of Erb's palsy, sorry. With Klumpke's palsy, it's making the hand clawed. And the way you can remember which one is which nerve root is that in Erb's, that comes earlier on in the alphabet. And so it's got the higher nerve roots, which is C5-6. Klumpke's is C8T1.
Perfect. Another question image, sorry. Limitations of Kahoot. This one's another buzzwordy question. So we're sort of trying to play off the classical presentation of these things. Nice. So yeah, medial epicondylitis is what we know as golfer's elbow. Let me show the image. And basically what it comes to is that the flexors in your arm are going to attach to the medial epicondyle. And so when we damage it, we start to get a sort of painful and weak flexion. And that's why we do that particular clinical test.
Just to clarify, I think in the question it said outer part of the elbow, but yeah, it would be medial side. But I think we all got it. Golfers.
Right. Yeah.
Yeah.
Perfect. Bit too pathognomonic then. Somehow managed to make the patient faint during our examination, which is not a good thing. What happened? All right. So yeah, I'm glad that we all went for a drop in heart rate because that's how we're going to end up with fainting. Would someone like to talk about how the baroreceptors factor in?
Yeah, just I don't think we need to. It's a requirement to remember too much in the specifics, but just remember baroreceptors are essentially measuring your blood pressure. So increased firing leads to a drop in heart rate, and then reduced firing does the opposite. And I guess one way to remember it is that for some supraventricular tachycardias, you do use carotid sinus massage. So just think, if you put pressure on it, then what do you want to do in a supraventricular tachycardia? You want to reduce heart rate. So pushing pressure will lead to a reduced heart rate.
Awesome. And yeah, so just to elaborate on what exactly is happening when something like this happens and why we don't take both carotid pulses at the same time. Basically, when you squeeze or you like press on the carotids, you're tricking those baroreceptors into thinking that the blood pressure suddenly spiked because you're sort of like compressing that part of the artery, and that increases the pressure. And so because they think the blood pressure is spiked, they say, oh my God, we need to stop pumping so hard. And so they make the heart drop in its rate. And so when the heart rate drops, the patient will faint because they're not getting enough blood, basically. So we don't want to overload those receptors, and that's why you only ever take one carotid pulse at a time. Another question in the image. We're on the home straight now. Don't get too stressed over ECG because you will learn it again and again every single year, and every year a little bit more of it will stick. Oh boy. Okay. Would someone like to talk about this one?
Yeah, so I feel like a lot of these questions are just buzzwordy. Like if you see lead 2, 3, and AVF, you're thinking inferior STEMI. Inferior STEMI is your right coronary artery because that's the part that supplies the inferior wall of the heart, or the left ventricle specifically. I think it's a good idea, like even if you don't know the ECG so well in terms of interpretation, if you just know which leads correspond to which specific areas of the heart, and then a step further, like what artery does that correspond to, then you're going a long way. Because sometimes you'll just get questions with, oh, we saw a ST elevation in these leads, what artery was affected? As simple as that.
I think
Also,
what do you? Nope, no good. That was just
I
me.
was just about to add. Also note that while we do learn it as rules, there is underlying physiology, which is just the idea that where these arteries, like you're just thinking where the arteries are. And sometimes you can have a LAD, that the left anterior descending, that sort of wraps around underneath the bottom of the heart. So that could also be affected and show up and present like this, but that is also super rare. But yeah, just know that there are rules, but there are always exceptions to those rules.
Awesome. Right, questions? Okay, so usually we expect most of our leads to be up the right way. One of them we do not expect to be up the right way. Right. Oh, okay. Bad luck. So lead 3 is actually one of our classic leads. So like it actually gives us a pretty nice looking, typical looking trace. So we wouldn't be expecting that one. Basically what it comes down to is that most leads are kind of like at least a little bit oriented in the direction that the heart is meant to fire in. So they're all like basically pointing down, like sort of inferior and towards the left. But AVR, as like R stands for right, is pointing like exactly the wrong direction, basically. And so under normal conditions, because the heart is firing in the opposite direction, it looks upside down. And so you don't want to be in your OSCE telling the examiner that something has deeply gone wrong because AVR is upside down. Right, left heart failure. Again, very buzzwordy, but that's not always a bad thing when it comes to exams. Nice, we're all pretty confident in that. Perfect. So raised JVP and pain in the calves. Pain in the calves, if anything, it's actually a sign of peripheral vascular disease, usually, because it means that the calves aren't really getting enough blood. Raised JVP would be right heart failure because we've got a lot of backup in the veins, which will raise the jugular vein. Heart beating out of chest is just sort of palpations, which is usually an arrhythmia, but sleeping on 3 pillows at night is a sign of pulmonary edema. Actually, I'm not sure if that's the right term. My mind is blanking right now. But basically, we've got backup in the pulmonary circulation, and that means that when you try and lie down at night, that sort of half suffocates you, and so you need to prop yourselves up. So when you're asking your cardiac history, and if you're like to the patient, can you lie flat at night, and they say no, it's a good thing to ask how many pillows they sleep on, because usually they'll use pillows to prop themselves up, and how many they use can be a really good indication of how bad the condition actually is, and that can be quite useful for treatment.
And also ask if they sleep in a chair. Sorry, no, all good. Because sometimes you ask how many pillows and they're like none, but I sleep in a chair. So yeah.
Yeah, and obviously if they're sleeping in a chair, then they're fully upright, so that's actually worse. So important not to miss that one. All right. Yeah, this one's sort of just like rote learning a little bit. Staph aureus is usually a good pick for questions involving microbiology. Unfortunately, not in this case. Enterococci is usually more to do with sort of GI infections. So viridans strep is both a pretty common cause of infective endocarditis, and also it's very, very linked with dental procedures. So that's why we check in the cardiac exam, like, do you have really crap dental hygiene? Because if you do a bad dental hygiene and you have some sort of operation, then you may end up getting IE, infective endocarditis, if it wasn't clear. Very nice. All right, second to last question. And it's going to be in an image again. A little bit more micro for you guys. All right, very nice. So yeah, strep pyogenes is a very easy one to confuse for it. I know I did many times when I was in year 1 and year 2, but Clostridium perfringens, the name almost sounds like something that should like bubble up your skin, but that's the one that is usually associated with gas gangrene, which is what we are looking at here. And our last question, will we be able to close that gap? We've ambushed you with a EBM question. This one is actually one of the more important concepts, so it's good to know the difference between these two. All right, okay, we got unlucky on this one. So basically, it's not really about forward or backward, okay? Because even though it's called a retrospective cohort study, that doesn't actually mean that it's looking backwards. It looks forward, but after the thing has already happened. So it's like we're looking forward in time from a point in the past, okay? Which seems a little bit confusing, but I promise it makes sense. But the case control is basically saying we're going to look at people who have the disease and use that as the basis of our investigation. And so that shapes how you look at it, and you're basically trying to find correlation because you're like, okay, well, what is linked to this disease? What if you have this disease? What is that? What are you likely to also have? Whereas with cohort studies, we actually get a bit closer to causation because we can say, okay, well, when people are exposed to this thing, they're like 900% more likely to get this disease than the general population. So case control studies are not actually very good at causation. Obviously, randomized controlled trials are the very best, but cohort studies get us a little bit further in that direction. All right, with that, I think we are to the podium. So congratulations to, I'm pretty sure one of the smiley faces. Question is which one? Awesome. Right, we can't beat the classic apparently. So well done to smiley face with one mouse, winning that one. And yeah, so what we're going to do, let me turn that off. What we're going to do for the rest of the session is to basically, I think I might still be sharing sound. What we're going to do the rest of the session is basically really quickly run through a few ideas on how to approach year 2, like ideas about notes and study, and then we'll open up to you guys. And if you have questions that you'd like to ask straight away, feel free to chuck them in the chat and we'll do our best to answer them. So I'll hand it over to Janam.
Yeah, okay. So I'll keep it really short and sweet. Like the main thing that I wanted to reinforce to you guys was 2 major messages. The first is the importance of active recall. And I think anyone here who uses Anki or like, I don't know, turns their like content into questions to answer, I think you probably already know the power of active recall because it's getting your brain to think on the spot rather than just passively reading notes and things like that. So one thing I'd recommend is if you're not a fan of Anki, which is completely fair, like I didn't use Anki that much. One thing I would still recommend is take all your content and try and write questions for yourself that you think might be something that you could see in an exam. And then test yourself with that as often as you can on as many days as you can. And ideally you want to set up like a schedule for yourself so that you have like graduated learning. So maybe like, okay, once I watch a lecture and once I form my questions, I will look at that question again in the next half an hour, and then the next 2 hours, the next day, the next week, the next month. As long as you've seen it like 5 or 6 times before the exam, and they're like solid, good questions that have appropriate responses, I guarantee you that you will remember those things regardless of how confident you are in your memory techniques. So it's not like you need to rote learn. It kind of is like, it's like rote learning, but with many days in between. So like you don't feel like you're doing a huge amount of just sitting down and memorizing stuff, because it's always just happening subconsciously in the back of your mind. So that's the first thing I would say. And for anyone who's seen the notes that I've put up on the Google Drive, if that's something you're interested in, I've kind of converted all the content that we had in our lectures into questions by topic. So you can, like, if you're an Anki person, you can convert them into Anki cards, or you can just use them as is, like see the question, open up the toggle, and you can look at the answers for whatever question you're looking at. But make sure you're doing this consistently, because it only works if you do it like that. The second major tip I want to give you, and this is kind of, I feel like throwing shade at ourselves as well a little bit, but also just to every PSP out there, as well as like all the resources you'll ever be given. Like as a medical student, you'll be given 100 different things that you could get resources or information from. And my tip to you is try very early to figure out what is the useful stuff for you and things that you really can relate with and understand. And what is stuff that is like really good, like it gives you a huge amount of knowledge, but it's not realistically something you're going to be revising every single day of the week. So for example, if you really love PSPlatypus slides, like obviously that can be your one resource, then the lecture slides can be another resource, then your own notes can be another resource, etc. But try not to overwhelm yourself, because you could have like 10 resources for one lecture and that could take a whole day. So try not to overwhelm yourself with those types of things. And don't be scared when you see like either our PSP slides or other PSP slides, or just like massive lectures with like 100 slides in them. Don't be scared when you see that much content, because remember, at the end of the day, the reason why that content is important is because it'll allow you to pass the exam that you'll be sitting at the end of the year or at the end of the semester. So the main thing is make sure that you have the learning outcomes with you, and make sure that you are trying to hit those at a bare minimum. And then anything extra is stuff that you can take on with you, just kind of as extra little interesting bits of information. So even with like the notes that I put up, I know a huge amount of it is just like stuff taken from lectures, and it probably is not going to be relevant to your exams, but I put it there anyways for your interest. So I would encourage you, don't do all of them. Just pick the ones that you think are actually going to be worth a lot of marks at the end of the day. And that's not just buzzwords. That would be like concept-based things as well, which I'd highly recommend. So those are my 2 main tips. And I'll pass it on to, I don't know, who wants to go next?
I'm done.
Yeah, let's go, Deepak.
Oh, okay. I think Hashiko's was too, but okay. But yeah, first of all, pat yourselves on the back. Good job on getting through year 1. Big props to getting through anatomy first time. Dude, that content was pretty heavy, right? Like there was a lot of work. And unfortunately, it definitely does sort of maintain that level of intensity if you let it. So a lot about what we learned in pre-clen, something that I want you guys to take away is that sooner or later, you're going to be on wards, and sooner or later, this information that you are learning right now is going to be something that you're probably going to reflect back on. And I think because of that, it is useful if you know how to get back to that like info quickly. So some people take notes, and that is a good idea a lot of the time. Some people like to just screenshot slides, which I also think is a good idea. Whatever that helps you synthesize information and keep it in an organized manner would be pretty useful. For example, like I just started I'm going to head into acute gen surg, and my surgical tutor was like, brush up on gallbladder pathology. And then now I'm faced with the idea of, well, what sort of resource stream do I want to pursue, right? Like in pre-clin, we've got lectures, like what Janam said. I think it's actually extremely important to limit the amount of info streams that you have. Make things simpler for yourself. All I did was pick a couple. So I would read the lecture slides, I would go through the PSP, and then I'd convert the PSPs into Anki cards, active recall, and that was my study strategy done for pre-clin. Something that I also want to introduce to you guys is an app called Remnote. So you might have heard of Notion, a big productivity thing that's all over YouTube. Now, Remnote is basically a combination of Notion, which is a note-taking app, with active recall built into it. So if I'm just gonna quickly share my screen super quick. This is, can you guys see? Yeah, okay. So this is basically what it looks like. So if you used Notion before, you might realize that it looks pretty similar to Notion. So it looks pretty aesthetic. But the key function of it, which I really like, is it allows you to figure out or think critically about what information you want to retain from what you're learning. For example, I have a lecture on, obviously, like what I was working on just then was gallbladder or gallstones, right? So I have a bunch of conditions that occur due to gallstone formation. Now, I want to know what these things all mean. So instead of writing it down, and then if you use Anki, you have to go through another procedure where you make flashcards. You can just use, you can just double click colon, which sort of highlights this as one face of the card, and then whatever you write here will be another face of the card. And then if you go to flashcards here, and then that will just allow you to go through your flashcards with it, which I think simplifies the way that you want to sort of have a pipeline for your knowledge to get into your brain, because you're just using one app. But yeah, that's my plug.
Yeah, and I'll just build on what Janam and Deepak both said. So in terms of choosing specific streams of information to use, as everyone said, it can be overwhelming how many resources we have access to. So for me, I pretty much just turned my notes into a little textbook for myself. So I take what I needed from PSPs, from lecture slides, and put literally everything that I thought could potentially come up ever in my notes, and then made Ankis on the important stuff. So now when I do have a question, I go back to like that semester, that subheading, like whatever I have, and then I look at my notes there. So find a way to, I guess, bring all the information together so that you're not ever at a point of, oh, I remember reading about this, but I don't remember where, if that makes sense. The other thing I'd say is that I think in year one, towards the end, especially, a lot of people figure out what works for them and what doesn't. And if something didn't work for you, don't keep doing it. I think a lot of people did, like if a certain note-taking system doesn't work, don't keep doing it. Ask around and try things. And when we say try different things, we don't mean try it for like a day or two, like actually give it a go. Because, you know, even the fact of trying something new is going to be hard, and it'll feel weird and it'll feel really clunky. So give things a go if things aren't working for you, and figure out what works best, because you will end up using that system going forward. You don't want to constantly be swapping between different formats of taking notes, different formats of learning.
Perfect. Anything else you want to say, or was that it?
Oh, I mean, sidetracking, but enjoy pre-clin when you can. Oh my God, go to uni, man. Don't just stay at home. Enjoy uni life. Yeah, I think get involved in other stuff other than med. It's a short life. And I think it is not best spent on pre-clin knowledge that you'll eventually have to relearn most of the time. So yeah.
And
Yeah.
make sure you practice getting enough sleep.
Yeah, all of us are starting clinical placements and suffering from extreme lack of sleep, so take it from us.
All right, I
General
guess I
features, sorry?
can,
Yep.
yeah, I can build on the collective wisdom of the group so far, I guess. So I guess other things that I would recommend, a strategy that I used a lot was summarizing. So you'll notice that when it comes to the content you're getting from lectures, it's very overwhelming. A lot of random niche stuff that your lecturer is probably researching about and cares very much about, but has no bearing whatsoever on, you know, passing your exam, let alone clinical practice. So I think it's very important that whatever information you write down during lectures, if you do, you sort of present it in a summarized form so that it's easy for you to access and read and then revise for the exam. And the way that you can do that is during your lectures, you'll be given learning objectives. You can use those as the basis for your summary notes. And then depending on how you learn best, like for example, I learn very visually. And so what I like to do is for a certain topic, especially for anatomy, I would like to make handwritten notes on a particular topic because that allows me to get screenshots from an anatomy model and then annotate it and then figure out my understanding of the 3D anatomy in that way. And yes, my second tip as well is figure out how exactly you learn best. Some people like using Anki because of this, the fact that just over time they build up that memory and you just can remember the content very well. Whereas some people prefer to, I don't know, they might not be as conducive to Anki and prefer to take it a bit slower with the content and go in more detail. There's pros and cons to both strategies. One is that, you know, you might get sidetracked with going too far into the content. But I think find what works best for you and then really try and find a system that allows you to do that. So for example, back in year one, I was very idealistic and I thought I would make handwritten notes and draw out everything for anatomy to make it all make sense. But then I soon came to realize that for myself, at least, drawing out every single thing or annotating every single anatomy picture, specimen, imaging thing wasn't always very practical. And so I ended up using written notes because they were much faster, not written notes, typed notes, because they were much faster and easier to get done as opposed to writing everything out. But again, you'll sort of figure out your own strategy. So those are my two strategies: to summarize and figure out how you learn, and then create a system that allows you to do both those things.
Yeah, I think that pretty much sums it up.
Wait, James,
so,
did you want us to like
yeah.
show or share anything like examples of how to do that?
Look, if you want to, I'm conscious of time though. So like we'll see how we go. If it comes to it, we might actually chuck up a video with some of the same concepts, just sort of encapsulated, because I know Yajat also had some stuff you wanted to share. So we'll see about that. Yeah, I think we're going to stop the recording in the session in a sec, just so in case you guys have any questions you'd like to ask but don't want to ask on camera. So if you're watching this online after the fact, because we will upload it, we do encourage you to come to these sessions live, because obviously there's a lot of value in testing yourself like as it happens, because like when you watch online, it can be very easy to say, oh, I would have gone with this thing. Whereas when you're forced to give an answer, I think it's usually more effective. So yeah, so from next week, we'll actually be covering year 2 content. So we'll be doing the week 1 stuff from the videos this week. So hopefully that'll be a really good chance to check what you've learned and check what you still need to work on. So thanks very much.